Yeah, I think we'll get going. A few more people will probably drift in, but I think we're going. Well done for staying. It's been a long day. These are long days. I think there was 12 hours yesterday, but we're approaching that. So thanks for coming. So this symposium really is data from both the program of social recovery work I'm involved with and also Cathy Greenwood's studies on early youth engagement, and we're presenting some data around that. So I'll move straight on with Cleo, who's talking about hope as a mediator.
Yes, thank you. Great. So I'm going to share some of the studies that I did as part of my PhD work with Cathy, and so focusing on hope as a mechanism for promoting social inclusion in early intervention in psychosis services. Then I'll talk a little bit about a more recent study looking at individual narratives of hope in early psychosis. And I'll share just a few kind of key thoughts about hopefulness across kind of age and mental health spectrums. So the kind of model of hope, the theoretical model that I use is this one from Charles Snyder. So it's hope as a cognitive set. The hopefulness is always directed towards a goal, towards attaining a goal. And there's two kind of key ingredients, I suppose, to the hopefulness. So one of those is agency thinking. So that's goal-directed determination, one's belief that one can kind of achieve a goal. And the second one is pathways thinking. So if agency is the will, then pathways are the ways, they're the means, planning the actual ways in which you will kind of achieve a goal. And achieving or not achieving a goal and kind of experiencing stressors or barriers in goal pursuit, both of those things give rise to emotional experiences which reinforce the kind of the pursuit of the goal. They reinforce the hopeful thinking, but they're not kind of part of hopefulness per se. And there's different types of hopefulness. The one I'm most interested in is domain-specific hope. So at the kind of underlying level, we have the more global, general trait hopefulness, and then we have the very specific kind of hopefulness that's focused on one particular goal, and domain hope is somewhere in the middle. So domain hope means hopefulness across different key life areas. So we can think about social hope, we can think about work hope, academic hope, family hope, and so on. And the reason that I'm particularly interested in it is I think if we're talking about social outcomes in psychosis, then arguably it's going to have more predictive validity. It represents more kind of concrete hopeful thinking, more concrete goals in those key life domains. Whereas if we think about global trait hope, I suppose it's more abstract, and it's potentially more of a sense, a promise of hope, the idea that somebody can call on hopeful thinking if they need to. And I'm sure that I'm kind of preaching to the converted when I say that both hopefulness and social inclusion are important to personal recovery in psychosis. Social inclusion, I think, is developmentally really important as well. And when I talk about social inclusion, I suppose the distinction is, the way I think about social inclusion is that it represents somebody's relationship with society. So the more traditional kind of social functioning outcomes, social network size, things like that, they're relevant. But there's also an element of somebody's subjective experience of belonging and mattering, so something slightly different. And I think we know a fair amount of correlates of global trait hope in psychosis, and some of those very relevant to kind of social outcomes, social inclusion. I don't think we know very much about domain-specific hope. I'm not aware of any studies in kind of psychosis, so if you are, then please let me know. But I think we've got fewer studies of hopefulness in early psychosis anyway, so I think it's an interesting area. And I suppose as in kind of doing my PhD research, I was interested in early intervention services, I was interested in community services and kind of how they function, how they make a difference, and particularly how they might promote social inclusion for young people with psychosis, and whether that seems to be through the provision of a hope-inspiring environment. So Do they provide a hope-inspiring environment? Does that seem to be through the therapeutic relationship between professionals and young people, a positive, secure bond, a shared focus on goals and tasks? And also something that was mentioned in the Satellite Symposium last night, what about staff's own kind of hopeful expectations of what people with psychosis can kind of go on to achieve? We've got bits of evidence, so we've got some evidence that therapeutic relationships do predict social and occupational outcomes, and that is potentially through a mechanism of global trait hopefulness or self-efficacy. And an interesting study at the bottom there which found that when professionals had more hopeful expectations about what people with psychosis in general, so not specific patients, but people with psychosis in general, when staff were more hopeful, that actually predicted how many days in employment service users working with them engaged in over the next 2 years. So a bit of emerging evidence that staff or professional expectations might be important. So we found 51 young people experiencing psychosis and their care coordinator. So we recruited in dyads, so 51 willing to take part. Quite a broad age range, so 18 to 37. Professionals were, as I say, all care coordinators, mainly nurses. And what we did at baseline is we asked them both to rate their perceptions of the therapeutic relationship with each other, looking at both the working alliance and any expressed criticism, hostility, things like that. The professionals also rated their general hopeful expectations about what people with psychosis can achieve. 5 months later, we asked the young people to rate their domain-specific hopefulness across kind of 6 key life domains. And we also took multiple measures of things that we thought would kind of capture social inclusion. So looking at social network size, reciprocity, looking at the more kind of subjective indicators of mattering. And we also looked at whether, just kind of quite crudely, whether people were engaged in any vocational activity and whether that had changed since the baseline. And then we looked at some directed path analysis to try and look at these associations. So the hypothesis was that the data would be consistent with therapeutic relationships predicting social inclusion via a kind of mechanism or mediation by domain hopefulness. So you have the 2 kind of mean scores representing social inclusion on the right-hand side, so social activity, community belonging. And we're first here looking at the therapeutic relationship as rated by the professional. And we do find that it predicts social inclusion 5 months later, and we do find significant indirect effects through domain hopefulness. When we look at the therapeutic relationship rated by the service user, we find the same thing. So that predicts social inclusion with significant indirect effects via hopefulness. And when we look at professionals' expectations, it's the same story again. So slightly less evidence that there's a kind of strong association between the professional expectations and the social activity aspect of social inclusion, but we do still find those significant indirect effects. So very similar. We also looked at change in vocational activity, so whether somebody was engaged in either work or study or both at follow-up, controlling for baseline vocational activity. And what I've circled here are the indirect effects. So it's the same story. So we're finding that the 3 kind of variables that we've entered as predictors, so the relationship and professional expectations, predict changes in vocational activity via the mechanism of domain hopefulness. We did also look at reverse modelling, where we changed the position of the mediator hopefulness and the kind of social inclusion outcomes. On the whole, the data are more consistent with hope acting as the mediator, except for one. So we've got some evidence that perhaps the therapeutic relationship as rated by the professional more directly predicts a change in vocational activity, in turn predicting greater hopefulness. But aside from that one, the models are consistent with hopefulness being a mechanism by which professionals can kind of influence social outcomes, social inclusion. So subsequent to that, I think we were interested to see, so this is a more recent study conducted with Victoria Bonnet, who was a student, and we were interested to know how do the findings from study 1, how do they resonate with the way in which young people describe their own experiences. So we were interested to know what stories do young people tell about their hopefulness? Does this idea of hope across or within different life domains, does that seem to have meaning? What role do they play? What role do they see professionals playing in those narratives? So Victoria collected these stories, these narratives, and we analysed them. 10 young people participated, a smaller, more narrow age range, so 18 to 26, and a varying number of months since they reported experiencing a first episode of psychosis. They did tell definitely quite individual stories. There were differences. Some people described themselves as very hopeful, very happy before psychosis and didn't feel so happy or hopeful afterwards. For other people, it went in the reverse. So actually they talked about their lives being quite difficult, quite bleak, not having any hope before psychosis, and afterwards seemed to have more hopefulness, more sense of momentum. We also looked at strands across the narratives. So there's a overarching strands that talks to the experience of hope, and then 3 further strands that talk about things that might be important to the inspiration of hope. So the experience of hope, so the young people themselves actually seem to make a distinction between hopefulness that's more emotional, that's more of a general feeling, and hopefulness that's more directed towards a specific goal. They quite readily gave examples of goals in different life domains and hopefulness in different life domains. They also, in the middle section, they talked about hope as being both relational and personal. So there was this really nice idea that there's almost a collective well of hope that we can all dip into, take away from. If somebody runs out of hope, you can try and push it towards them. So some really nice images. Whereas Sam also points out the privateness of hope and the personalness of hope at the same time. There were some interesting things about the timing and nature of hopeful discussions. So Sam had quite a lot of really interesting things to say, and he was thinking about the idea of hopefulness as this positive, future-oriented cognition, and he said that potentially it's quite a difficult thing to think about, because if I think about hope, then maybe that tells me that there's something now that actually isn't okay, isn't as good as it could be. He also talked about the recovery period being more appropriate to think about hopefulness, compared to the complexity and the confusion of during psychosis. So he says, just before the quote, he says, where is hope in that experience of psychosis? And he says it's actually multi-layered. It's hope and despair and desire and excitement and fear and loss all at the same time. There was a sense in the narratives that young people almost did seem to find it easier to talk about domain-specific hope compared to hopefulness in general. So there's a lot of text at the bottom, but the reason I put it up there is the left-hand side is Mark when he's being asked to talk about hope in general. And the narrative tone is quite faltering. He finds it difficult to answer the questions, and it slips off the bottom, but he actually says, this is really, really hard. The questions are really, really hard. And that, for me, really contrasts with on the right-hand side, and that's when it's suggested to him, well, what about hopefulness in particular life domains? Can you say anything about that? And there's much more sense of fluidity and flow in that section of his narrative. And he says, I'm hoping to get a job. I'm handing my CV in after this. I've got hope in my friendship groups. I'm hoping to get qualifications. And again, slips off the bottom, I'm hoping to do an apprenticeship. So definitely for him at least some sense that it's easier to talk about hopefulness. So information and explanation could be both hope-inspiring and otherwise. People associated being given information about things like hospital and prognosis that helped them to feel hopeful. And when they weren't given information, sometimes it to them that was a message that things weren't going to get any better. A sense of belonging came out in these narratives as a general sense that if somebody is really listening and showing an interest, that raises hope. And people said some quite interesting things about encounters with professionals as well. So the professionals, the kind of perception that they were hopeful and positive people, that seemed quite important. A sense of coming together and forming a collaborative plan, again, that seems important. That seemed to kind of help young people feel that sense of agency. And Sam talks about the fact that, so kind of contrast therapeutic and non-therapeutic encounters, and he says that therapeutic encounters are ones which help you to kind of function, they help you with your functioning capability. Planning and occupation, so planning seemed to be important in terms of breaking down goals into smaller goals, and there seemed to be a reciprocal relationship with kind of productivity, occupation and hopefulness. So that's what young people had to say. Very brief points about a kind of a study that we did in the general population with a much bigger sample. So we took the same measure of hopefulness and the same measures of social inclusion, and we also measured dysfunctional attitudes and more negative self-belief just for kind of comparison. And this is a structural equation model, so I'm not going to go through this in any detail, but just social inclusion in orange on the right-hand side. We've got domain hopefulness here at the bottom. Across our whole sample of 387 14 to 36-year-olds, we find that social inclusion is predicted by both hopefulness and dysfunctional attitudes. Something quite interesting happens when you look just very crudely at young people that said, I don't have a mental health problem, I've never had one, versus people that say, I have previously had a mental health problem or I possibly do. So what we find there is that in the previous possible group, only hopefulness seems to predict social inclusion. And if we look at a split by age, we find the same thing. So in the 19 to 36-year-olds, both hopefulness and negative self-belief seem to be important. If we look at our adolescents, our 14 to 18-year-olds, then only hopefulness seems to predict social inclusion. We also looked at the dysfunctional attitudes and correlation with social inclusion in psychosis, and there were no significant associations. So it seems to be the case that hopefulness is perhaps more closely related to outcome in psychosis and in mental health. And it's also more closely related to outcome for adolescents compared to young adults. So the conclusions that I've kind of made so far is that hope as a cognitive set potentially has kind of meaning and relevance in psychosis, perhaps especially so the domain-specific hopefulness. It's linked with social inclusion. It seems to be both relational and personal, and perhaps there's some differences when you look at kind of mental health groups and age. Professionals can inspire hope through different ways, so therapeutic relationships, providing kind of hopeful expectations, and perhaps considering the way that they have those discussions about hopefulness. And then just to acknowledge all the people that I've worked with. So thank you very much.
Hope is really key, I think. It's a key mediator of the therapies that we've been talking about, and also instilling hope in supervisors and therapists is a lot about maintaining gains and things like that. I'm really aware of the time, and I think what we'll do is have questions at the end so that we can have it through. So we've got two talks on processes. The next talk on processes is on negative symptoms, and then we've got two talks on outcomes of therapy.
So I'll introduce myself whilst I'm waiting for the slides to come up. So thanks, David. My name's Bryony G, and I'm from the University of East Anglia. And I'm really pleased to have the opportunity today to present some of the findings from my PhD research. My PhD was looking at the relationship between negative symptoms and social recovery using a mixed methods approach. So what I'm going to be talking about today. So first of all, I'll give some background about the relationship between social recovery and negative symptoms. Then I'll talk about some of my quantitative findings. then about my qualitative findings, and I'm hoping that I can really bring them together and show how qualitative work can potentially explain some of what I found in my quantitative work. So to first of all, just briefly define what I mean by negative symptoms. So they can be split into two domains: diminished expression, encompassing blunted affect, so decreases in emotional expression, as well as decreases in verbal expression, so alogia. And then the second domain is withdrawal. So that's withdrawal from activity, from pleasurable experiences, and from other people. Okay. So the relationship between functional outcome and negative symptoms is very well established. And we know also that negative symptoms that persist despite treatment are of particular prognostic importance for social and functional outcomes. But we haven't looked yet at the kind of more nuanced relationship between change in negative symptoms over time, so negative symptom trajectories, and change in functional social outcomes over time. So that's what I was hoping to do. But in order to be able to do that, we need to be able to quantify recovery, social recovery. So it's agreed both by professionals and by service users that social and functional outcomes are an important indicator of recovery. But there's no consistent way of measuring these. And we have no current consensus criteria for what counts as a good functional outcome. So the work we've been doing has been using the time use as a way of measuring social recovery. So what the time use does is it asks the young person about everything they've done over the past month. So it's a bit of a memory test for the young person. And what we're trying to do is gauge how much time they've been spending in specific activities. So that includes work, whether it's paid or voluntary work, education, childcare, housework, sports, and structured leisure activities. So leisure activities outside of the home with other people generally. So information on those activities is gauged via this semi-structured interview, and we use it to calculate the average amount of time over the previous month per week they've spent engaged in structured activity. And I think it's a really great measure to use when we're looking at the relationship between social recovery and negative symptoms, because it has limited conceptual overlap with negative symptoms. So some of the measures that you'll sometimes see used to measure functional outcomes, some of the more the measures that perhaps look more at the quality of functioning, they can be actually really similar to measures that are trying to capture negative symptoms. So that's obviously quite problematic if you're trying to look at the association between the two, if actually your measures are kind of capturing the same thing. So using the time use overcomes that to an extent. The data that I used was from the Eden Programme of Research, which was a large mixed methods evaluation of the impact and cost effectiveness of early intervention services in the UK, specifically in England actually. 1,027 people were recruited. So they were recruited on entry to the participating early intervention psychosis services, and they were followed up over time. So in the first phase, National Eden, they were followed up on entry at baseline, at 6 months and 12 months later. And it's that data that I've used in the quantitative analysis. Negative symptoms were measured using the PANS, but I should enter the caveat that I haven't used the negative subscale from the PANS. In my modelling, I used a kind of bespoke negative symptom subscale based on exploratory structural equation modelling, because we know that the negative subscale of the PANS captures some things that now aren't considered to be part of the negative symptoms construct. And then social recovery was assessed using the time use. And also available as part of this data set, as I said, it's a mixed methods evaluation. There was a really large set of qualitative in-depth interviews carried out with participants. I think there was nearly 900 interviews carried out in total, so it was a huge, huge qualitative data set. So I was really excited to be able to get my hands on that and have a look at the experiences of the young people. The participating services were from a diverse group of regions around the UK, and they were consecutively recruited young people, so everyone who came into the early intervention services between 2006 and 2009, the recruitment period, was invited to take part in this study. And I think about 50% agreed to be part of EDIM. And there were no significant differences in the demographic variables of those who chose to take part versus those who didn't. So we can assume that this is a roughly representative sample of young people coming into early intervention services in England. So what did I do with all this data? So first of all, thinking about the quantitative analysis. So I used a technique called latent class growth analysis. So I thought I'd just explain what that is in case you're not familiar with this technique. So what we have up here is the trajectories of all of the people in the sample. So these are the individual negative symptom trajectories. And as you can see, it's a bit of a mess, it's a big jumble. So it doesn't tell you all that much just looking at that picture. One way to model this data would be to just stick a line through the middle. So that's what would happen if you try to model this data using a single trajectory. But obviously that's not capturing the huge amount of variation that there is in this sample in negative symptom course. So latent class growth analysis allows you to separate up some of that heterogeneity and to create groups that follow similar patterns over time in your variable of interest. So in this case, it separates it out into groups who follow similar patterns in their negative symptom course. The model that I chose was a full-class model. You choose the model based on a combination of statistical considerations and also parsimony and interpretability. So there is some subjectivity in this. But this is the model that I felt best represented our data based on all those considerations. So what we have is a group at the top who have consistently high levels of negative symptoms throughout their first year of early intervention. It's quite a small group, so it's only about 5% who have that persistently elevated level of negative symptoms. Then we have a smaller group, 13%, who have kind of stably elevated negative symptoms, but at a lower level. At the bottom, we have most of the cohort, so nearly 64% of the cohort have stably low levels of negative symptoms throughout, so consistently pretty minimal. And then we have what I think is probably the most interesting group. We have this group that starts with quite high levels of negative symptoms, but then they decrease over time. So about 17% of the cohort fell into that trajectory group. Okay, and the same thing was done with social recovery trajectories. So this was modelling time use data. So here we have about 7% of our cohorts. They start out with really quite high levels of functioning. Maybe too high, I'm not sure. So bear in mind, David mentioned earlier that in an age-matched healthy control sample, the number of hours per week in structured activity is around about 65. So the group at the top, the high decreasing group, starts really quite high and it comes down to a level that's about in line with an age-matched healthy control sample. Then we've got 27% who start at a relatively low level, relatively modest level of time use, and their structured activity increases over the course of the first year of early intervention treatment. And then at the bottom, we have a rather large group who have consistently low levels of negative symptoms throughout. So 66% don't seem to be making much for social recovery during the first year of early intervention. So what we then did is look at the relationship between these two groups. So we looked at the social recovery trajectories of members of each of the negative symptom trajectory classes that we identified to see whether there is an association between the trajectory of an individual's negative symptoms and their social recovery over the first 12 months of early intervention. Perhaps unsurprisingly, there is an association that fits with everything that we know. So these three groups at the top are the groups that had elevated negative symptoms at baseline, and all of them are overrepresented in the low stable social functioning category. And this is just showing the same information in a different way. So here we've classed those who had high levels of social functioning that decreased to sort of the normal range, and those who had initially low levels of social functioning that increased, but also to within the normal range. We defined those as having made a good social recovery. A little bit crude, but I think it serves a purpose. So you'll see that all of the groups that had elevated negative symptoms have really quite low levels of the group are making a good social recovery. Actually, I think the picture across all of the groups is none of them are actually making a particularly great social recovery. So even those with consistently minimal negative symptoms, you're not having a massive percentage of the group that are making a good social recovery. But the one that I found particularly interesting is the high decreasing group. So this wasn't what I was expecting. So I was expecting that as levels of negative symptoms decreased over time, that would be mirrored by a corresponding increase in the amount of time they were spending in structured activity. But you don't seem to be seeing that. So flicking back to the previous table, that high decreasing group, so the group whose negative symptoms were high but had remitted within the first year, they're nonetheless overrepresented in the low stable social functioning class. So yeah, I thought that was really interesting, not what I was expecting. So that raised some questions. Why is that the case? So one possibility I thought of was potentially they were just coming from a lower baseline. So we looked at some of the predictors of being in the high negative symptoms group. And being in the high but decreasing group was predicted by having poor premorbid adjustment. So it might be that actually they just have harder to work because they were coming from a lower baseline. So maybe it's just taking them a bit longer to get back. And maybe there's just something of a delay there. So just because your symptoms have decreased, it might take a little while to kind of build up the amount of activity you're doing. So you can't always start getting back into things that you value and enjoy straight away. It might take a little bit of time to arrange a place on a college course or to find out how to join a football team, something like that. So maybe it's just a bit of a delay. But it raised some questions about what is the nature of the relationship between negative symptom course and social recovery during the first episode of psychosis. I think there's often an assumption, it's kind of implicit in a lot of the papers that I've read, that the association is sort of a direct causal relationship. So having high levels of negative symptoms leads to poor functioning, which is quite intuitive. But the fact that even those where the negative symptoms are remitting, they're still experiencing difficulties in social functioning, made me think, are there other ways that we could look at this? So I looked at the qualitative data to try and see if we could find some clues. So as part of the qualitative work, I explored the experiences of recovery of the young people that were part of those trajectories. So because qualitative work is quite in-depth and quite intensive, it obviously wasn't feasible to look at the experiences of all 1,000 of the cohort. So I selected a purposive subsample of the cohort. They were from across each of the negative symptom trajectory groups that I identified, and I compared the experiences of members of those groups. So there was a series of interviews available. So there's a total of 57 interviews I selected from 24 participants from across the groups. And I explored potential kind of contrast similarities between the experiences of recovery of each of those groups. Okay. So in the interest of time, I'm just going to share a few of the themes that emerged that I think might be relevant, and some of the quotes that came directly from the participants' interviews. So first of all, perceptions of recovery. So I was interested to find that there seemed to be a real difference in the way that participants were describing recovery, depending on which group they were in. So those who had high levels of negative symptoms, so including those who had stably elevated and those who had high negative symptoms initially that remitted, both seemed to have quite high benchmarks for recovery. So they were saying that it's necessary to be back in full-time work, to have no symptoms. That's what they would consider recovery. If you contrast that to this quote from a woman that I'll call Jennifer, who had minimal negative symptoms throughout, her definition of recovery, that it's being able to enjoy stuff in your day again, to be able to do part-time work or voluntary work. She was saying, obviously, full-time work would be the main thing, but I still think it's if you do voluntary work. And not necessarily not having any symptoms, but just not having symptoms all day. Okay. The next theme was about agency in recovery. So those who had elevated negative symptoms or high negative symptoms that decreased. Stop. Okay. Am I okay to just wrap up? Okay, yeah, only 2 more slides. So there seemed to be something about them perhaps seeing themselves as having less of a role to play in their recovery. So those with elevated negative symptoms often talk about their recovery being contingent on medication use, for instance. Whereas those who had consistently minimal negative symptoms were often talking about recovery being as a matter of learning to cope. Okay. So to bring it together, I was wondering whether these experiences of the young people in these trajectories could help explain maybe the gap that we're seeing between negative symptom remission and social recovery. So perhaps there's something about having a real sense of agency and coming back to hope in your recovery that might be promoting good social recovery amongst those who have consistently minimal negative symptoms. And that leads on to perhaps a potential role for therapies that can help encourage a perhaps more sort of adaptive attitude to recovery in order to promote social recovery amongst those who have negative symptoms, elevated negative symptoms on entry to early intervention psychosis services. Okay. All right. Thank you so much. I'm sorry for running over.
I think both of those talks give a really good overview of it, and it's a shame not to get it more. The patient's experience of negative symptoms, I think, is a really under-researched area, and how people experience it. And it's very close to the hope and lack of hope, the changes in negative symptoms, and it really provides a good insight into where it's about. I am aware of time, and we can stay on, but I'm aware some people may want to go. I'm going to move on. It would be nice to take questions at the end, which we have time for if people don't want to go. So the next study is a related study. So I went to Sussex, and I'm lucky enough to work with Kathy, who really complements our work. You can see with the hope and whatever, and her work's on a trial of early youth engagement. Engagement is the other sort of third thing of negative symptoms and hope.
Thanks very much. So, as David said, I'm going to be talking about a feasibility and pilot study around early youth engagement in first episode psychosis, with a view to better engagement leading to better social and other outcomes. And I've got a number of people who I've been working with in the Institute of Psychiatry, in Sussex Partnership, and in the University of Sussex, including Cleo, who you might have spotted in the middle. And also you may see a penguin there which says SURF's up. SURF represents our Service User Research Forum, who we've worked really closely with throughout all of this research. So what is the problem with engagement? Well, in England, around 7,500 young people develop psychosis for the first time every year. We know the consequences of that. We know that early intervention is valuable for a range of different reasons, and I'm preaching to the converted here. But we also know that around 25 to 30% of young people disengage from services in the first 12 months, whether you look locally, nationally, internationally. We know quantitatively that this is linked to things like younger age, to substance use, to less family involvement, less knowledge of services. But what we wanted to do was to understand this from the perspective of service users and their families, and to develop an intervention approach, an adapted early intervention approach, to promote better engagement outcomes. So this is just reiterating what I've mentioned, that we're trying to focus on this 25 to 30% of people who disengage. So the way in which we approached this was in 3 phases. So the first phase was to understand what are the facilitators, so I'm losing my voice, what are the facilitators and barriers to engagement in early intervention. Second, to look at those themes that emerged from phase 1 and use that to develop a new engagement-focused intervention, and the third to trial that in early intervention services to look at the feasibility and to see look for signs that this was impacting on engagement. So phase 1, we ran focus groups with 68 people. Phase 2, we ran a Delphi consultation with 27 people, and the final phase involved 298 service users, and I'm going to talk us through each of those phases. So the first phase, 68 people, 40 qualitative data sets, which is very large for a qualitative study, and which involved individual interviews and focus groups with young service users of our early intervention services, young people not currently using services, and this was important because here we were trying to tap into both local schools and colleges and young people who may have need of services in the future but aren't currently needing, but also to tap into the group of people who potentially had problems, for example, in homeless hostels and so on, who weren't currently engaged. And we also interviewed siblings and parents, and we were interested in the factors that influence engagement. And what we found was that there were 5 core themes. So one around communication. So what and how do we communicate with the young person and their family? A big one around social factors. How do we involve not only family but also friends, peers to support engagement? The face of the mental health service itself, and particularly how the early intervention service approached tricky issues around medication, around hospital and so on, and how that was communicated. Mental health staff, action, attitudes and knowledge, and also people's personal experiences around mental health, around service use, and also just personal preferences about how willing and comfortable they were to talk, who they engaged best with and so on. So we took all of those themes into our Delphi consultation phase with a lot more detail, lots of quotes, lots of examples, and we said to our national early intervention leads, clinicians, managers, from a whole range of different disciplines, this is what people are telling us they want, this is what people are telling us are important, what should we do about this? We went through an iterative process to reach a consensus on the key factors that we would take into our intervention. And these were a set of myth-busting booklets and a website which helped to address some of the issues with communication, being both hopeful and transparent about tricky issues. Lots of socially inclusive practice and building more on that in terms of social groups, use of peer workers, family and friends protocols and booklets. Doing some work with the mental health service around being more open, more accessible, using a treatment choice booklet, which I'll show you in a moment, and training staff to be more goal-focused, to have a more motivational approach and to be more transparent and open and hopeful and inspiring, and to try and address, where possible, some of the personal qualities that could be barriers to engagement around personal characteristics through the booklet and the website. So here's an example of the homepage of the website. Basically everything that went into this website was based on what young people and their families told us they wanted. So we had, for example, lots of information. We've got useful films on the website. We've got a lot of information about substance use because people found this something they really wanted to know more about. We had psychosis stories, both the story and the recovery story, so that you could hear both how the person was doing at the point that they entered the service and where they are now. Meeting the team. Self-help was something that people wanted to have access to, and we've got a group that reviewed apps around mental health and rated them to put up on the website. And as I said, we had 4 different booklets. So one around mental health and getting help, one around early intervention in psychosis, telling people what early intervention services do and how they work, because young people said that's what makes a difference to whether I engage or not, is actually what are they going to do for me. advice for friends and family in terms of issues they may face around stigma, around treatment choices and so on. And also a big issue for young people was around treatment choices. So they were saying that, yes, I understand medication is an important part of the treatment, but I want to know about other things as well. I want to know about diet, exercise, a whole range of different things and how they might influence my mental health. So the booklets were all about addressing myths. So some young people didn't realise young people have mental health problems. So we've discussed that. People were concerned about being judged and given a diagnosis. So we've been open and honest about those sorts of issues. As I said, it was important to say what an EIP service does and why it matters whether you engage or not. You know, how to get help, what happens after the service ends. The treatment choices booklet has been really popular, and we've talked about what each intervention is, what it does, how it works, what the evidence base is for it. We've got lots of quotes from service users and clinicians across a whole range of different treatments, including, as I said, things like diet and exercise, which, you know, may have less evidence for a direct impact on psychosis experiences, but obviously are very important in terms of your general health. And the final phase, having developed this motivational communication intervention, was to look at the impact on engagement and dropout. What we found was, so we had a cohort of service users before we started the intervention and a new cohort of people after we trained everybody and developed all the materials. We found that they were similar in a range of basic characteristics, although the first sample was a little bit younger. And we found a significant difference between the pre and the post cohort in terms of engagement and dropout. So what we actually found was the dropout reduced from 24% before we did anything to 14.5% after we did something, which relates to a number needed to treat of 11. So for a comparatively cheap and easy intervention, the initial indications are pretty positive. Obviously, we now want to move into an RCT design, which is our next step. But we were also interested in the feasibility, what was actually being delivered. We did a process evaluation to explore what was being delivered, and also a qualitative study on randomly selected service users, carers and clinicians. And we found of interest an indication that the more communication approaches that were used, in terms of things like the booklets and the website, the more likely a service user was to be engaged 12 months later. And that wasn't just because they were there to give the booklets to, because sometimes these were offered to people when they were in hospital at the first point of early intervention contact. And we were interested in people's experiences of the intervention, and we found sort of potentially positive impacts around what and how people communicated, around the nature of social involvement, the focus on hope, lots of mention about goals and practical focus, and lots of mention about more choice and collaborative approaches to treatment, because treatment choice booklets were being used. Service users and family talking about more trust, feeling reduced isolation and stigma. Families talking about feeling more reassured that they knew what they could do that would be helpful, and some service users who were actually on the verge of disengaging, saying that they'd gone onto the website and listened to some stories from service users which had made them feel less socially isolated, and interestingly able to reality check a little bit what they were experiencing. And interestingly, from staff, we also had lots more pride and professionalism in their service, because they really liked the fact that all the information that they needed was there to hand in really nice glossy booklets, and that they could kind of give this out to people. So the staff were very engaged in this as well. So we've got really good evidence supporting staff in implementing this around the booklets, the website, the family involvement. I can't spell motivational, but training was especially important for influencing motivational engagement and family involvement. And the project suggests that it reduces isolation and stigma, improves communication and social involvement, pride and professionalism in the service, and it may reduce dropout of 1 in 11 young people. And what we now want to do is test that in a proper randomised controlled trial in a much larger sample, because there were lots of service changes going on at the time, and this was really looking at feasibility and pilots. So that's our next step. Thank you.
It's an incredibly important study on systematic study of implementation, of which I'm not sure there's many about in terms of looking at it this way. My favourite thing on the thing is, why is psychosis not like a badger? It's kind of like... So anyway, should we take some questions? That would be really nice to do from any of the speakers. Has anybody got any questions of anything? Sure.
Did you look at the ethnicity difference in engagement?
I didn't look at ethnicity. I think that's an important point. I have to say that Sussex is fairly white. And so, I don't know how ethnically diverse it is. But one thing that we're focusing with the next stage of this study, if we get funded, which we're about to put in the proposal for, is to develop the materials to ensure that they meet the needs of an ethnic minority population as well as the broader group, although we did make sure that we included ethnic minority groups in our developmental phases. And then we can also look more specifically at differences, engagement, outcomes and so on, because I know that ethnic minority background sometimes leads to more disengagement, so I think that's important to focus on. Yeah.
Any other questions to anybody?
Thank you for your presentation. You talk about motivational engagement, motivational instilling hope. What is the real content of this? Is it real intervention? What is the background of this intervention?
Yeah, so we trained staff on motivational approaches, so motivational interviewing approaches, as well as focusing on different ways in which they could communicate and discuss risk-based information and difficult information more openly, more transparently, and at the same time focusing on young people's goals and their sort of needs. So it was those two components really, sort of motivational and open, and supporting that with all of the resources we have that are focused on those same aims. Yeah.
Any more questions? It's getting late. Okay, we'll finish it there. Thank you very much for staying. Thank you for